Professor Pertuiset, I'd like to commence by asking you a bit about your earlier education prior to graduation from medical school. You had told me earlier that you had, for example, considered art as your first choice when you were a young man.
Exact.
And that you were accidentally made into a doctor. I wonder if you'd relate how that happened.
Well, this is absolutely correct. I began to draw when I was 5 years old. And I began to paint oils when I was 14 years old. But I wanted to be a free man, like Stendhal. So I found a way. It was a way of Pirlotti, to travel without problem of money and to paint. And this was possible in the Navy. So I tried at first to go to l'École Navale. But this was a little too bit difficult for me regarding mathematics. So finally I found a way which was to become a medical doctor in the Navy. And my father agreed. So I went with my father to a school which is in Rochefort, and in which they form medical officers for the Navy. But when we arrived before the door of the school, it was closed. And it was closed because Hitler had invaded Czechoslovakia, and the school closed entirely for good. Then my father told me, "What are you going to do?" And I told him, well, if I cannot become a medical officer, I shall be a medical doctor. And this is how I became a medical doctor.
So it was only because of the, well, you can still conceived of yourself, though, as a person who wanted to keep his independence, who wanted to also be able to continue with his art. And nevertheless, to enter medicine as the vehicle for this freedom, or there must have been something more behind your desire to enter medicine than to maintain your independence or freedom to paint, to draw?
Well, I thought that medicine was a very nice way to behave in this world, because we do our best to take care of our brothers and to cure them from the devil, which is in the form of the disease. And this is probably one of the reasons why I began my medical studies with pleasure.
And
finally.
In which school did you enter?
Well, in Paris, the first year of the medical studies is devoted to chemistry, physics, biology, and so on. And I did it in Paris. After that, I was obliged to go to Rennes because the war was present, and my father, who was a businessman, went to Rennes, and then I followed. So my first year of medical studies was performed in Rennes.
Mm-hmm. And but you graduated, though, I think, from the Faculty of Medicine in Paris.
In Paris, yes.
Was that the old Faculty of Medicine building on the Rue Boulevard Saint-Germain?
Yes, that's right. It is called Rue de l'École de Médecine also.
Oui, on one side. I recall reading that there had been a statue to Paul Broca, Dr. Broca, somewhere in the old Faculty of Medicine building, which during the Second World War disappeared. Apparently the Germans took it, or are alleged to have taken it. Do you recall that?
Not at all. This is the first time I hear this.
Really?
But this is certainly true.
Well, I don't know. Is it true?
I don't know.
I don't know for certain, but that's what I was told. So what year then did you graduate from the Faculty of Medicine?
When?
What year did you graduate?
1949.
The Faculty of Medicine?
Yes, because in France, we do not graduate during our internship.
Oh, I see.
It is when the internship is over that we graduate, and we write a thesis for that.
Yes, but in 1944, you had been affiliated with the French Forces of the Interior, the medical unit in Paris, in case of an invasion of northern France, Normandy. You might be asked to go to assist any wounded allies, Allied soldiers who were caught on the beaches.
This is correct. I was a member of the FFI, which is the French forces in the interior of the country. And I was supposed, if there was a landing, to go on the coast and to take care of the wounded. In fact, it was a little different because it was impossible to go to the coast when the landing of the Allies began.
Yes.
And finally, I joined the army only after the liberation of Paris.
Where were you during the liberation of Paris? In medical school?
In Paris.
I understand, but I mean...
I was an intern.
Was there a disruption of civilian life and studies during those days? Mm-hmm.
No. Mm-hmm. We could live normally.
I see. But the Faculty of Medicine is very close to the Rue Saint-Jacques and Boulevard Saint-Michel, where much of the fighting occurred in August the 24th, 25th.
Well, it did not last very long.
No, I know.
At this time, I was in the Hôpital Boussicot, which is far away.
Oh, I see.
So there was no problem for me. My problem was to join the army in the best condition to learn what the British and the American had invented during the war in North Africa, in Sicily, and in Italy.
When you said to join the army, one would think that you meant the French army, but...
No, I joined the American army.
Yes. Under what circumstances?
Well, I had a master which was operating in the American hospital in Paris. And he created, I think, 4 teams of surgeon and anesthesiologists in order to learn what the Allied forces had invented, especially the anesthesia with tracheal intubation and the preserved blood, which we had not. So I joined the army of General Hodges, at first in the General Hospital, which was in Hôpital Beaujon, then after in the evacuation hospital, which was, I think, in Lunéville, and after that, the field hospital, which was in Brumat. And this is where I have seen for the first time the horrors of war, because this was during the Battle of Ardennes, and one day we received in a small hospital under tents 500 patients. How was it possible to take care of them? So we divided, not me, but the doctors who were working in this hospital with their colonel. We have separated those for whom we could do something and how you say abandon?
To abandon.
Abandon the others, which we estimate could not survive even after surgery.
The concept of triage, though, is the French concept that commenced with the First War. the First World War, is it not?
I was young at that time.
No, I don't mean I don't mean that you would have personal knowledge of that, but I think it was a French concept. The term triage itself would suggest that.
Well, it is very sad to abandon somebody,
Yes.
whatever he is, if he is
Yes.
German or if he is American or if he is French. But these are the horrors of war, which you can see very well in the Prado
Yes.
in Spain, Madrid.
Goya.
Mm, right.
You had mentioned earlier, prior to the interview, that an observation you made of a doctor performing neurosurgery during that period, the Ardennes offensive, was instrumental in your decision later to enter neurosurgery.
Yes.
I wonder if you might
yes.
mention the circumstances.
Yes. Just before the war, there was a professor of neurosurgery. I think he was nominated in 36, something like that. So not very far from the beginning of the war. And this man was Clovis Vincent. I knew from my friends that neurosurgery, under the chairmanship of this man, was very much complicated. He was necessitating 2 assistants, 4 nurses around the operating table, and 3 nurses in the operating theater. So I thought that neurosurgery was an horror. But in this evacuation hospital, I saw an American surgeon operating the wounded of the head with only 1 nurse. Very simple. And he had not many ways to know exactly what the patient had, because we had only X-rays, so plain X-rays. But I realized that neurosurgery was a possibility for me. So when my chief, Petit-Dutailly, asked me to follow him after the death of Clovis Vincent, I have accepted. And I should say because I have seen this man of which I don't know the name.
Mm-hmm. Prior to our going on towards the period after World War II, I wanted to ask you a bit about the earlier history of neurosurgery in Paris in particular, but it applies to all of France. You had mentioned that the Clovis Vincent's name as the professor of neurosurgery, he was at La Pitié Hospital. But prior to him, you mentioned that your mentor had been Professor Petit-Dutailly. And you had mentioned prior to the interview that Professor Petit-Dutailly, although a general surgeon and trained in general surgery, had done considerable neurosurgery as well. But because of his being a general surgeon, was not considered eligible for the eventual designation of the first professor in neurosurgery in France. Is that correct?
Absolutely correct.
And instead, Professor Vincent, who had primarily or had been a neurologist, working with Dr. Thierry de Martel, had gradually, through experience with Dr. Cushing on I think 2 occasions in Boston, had decided to try neurosurgery on his own. You had mentioned that he and Dr. Thierry de Martel had worked closely together over the years, and eventually that by operating upon an abscess successfully, I assume Professor Vincent had decided to establish his own practice of neurosurgery. And then the Rockefeller Foundation, through the recommendation, I think, of its Paris representative, Dr. Alan Gregg, had, with the cooperation of the Ministry of Education in Paris, obtained matching funds to to endow the first chair of neurosurgery. I'm not certain of the year exactly. It may have been 36. I was thinking 38.
I'm not sure.
But the service located at La Pitié. And after Professor Vincent's death, you mentioned that his successor was Professor Petit-Dutailly,
Right.
who was his contemporary, nevertheless, at the Salpêtrière, the adjoining hospital, just next door to each other, really. Is this not correct?
No, it is not absolutely correct because Petit-Dutailly, when he was taking the place of succeeding to Floris Vincent, was no more in La Salpêtrière. He had a service of his own, general surgery, in Hospital Bichat.
Oh, I see. Now, in what year did Professor Vincent die? I think it was
Yeah, after the war.
1948.
Yeah,
wasn't it?
something like
Something
that.
like that. Now, after your service with the American 7th Army, you then enlisted in the 1st French Army under
Yes.
General Delattre.
Yes.
And you said that that was in March 1945 at Colmar, where
Yes.
you joined
Right.
his army. And what were your responsibilities in the 1st French Army, in the medical corps?
The same as in the American Army. I was part of a team which was constituted by a captain, a lieutenant, this was me, an anesthetist, and a nurse. So this was the same team. And the team was disaggregated in Tuttlingen because the war was over and everybody went where he was sent. I was sent to Constance on the lake, and I had the duty to empty a hospital of 1,000 beds in Bregenz,
What type of patients were in those beds?
wounded.
You're Austrian, German? Or?
Austrian, German, Hungarian, Russians.
Oh, is including allies, like the Russians?
No.
Oh, those were Ukrainian?
No. Because there were, yes, that's right. There were Russians which were with the Germans.
They were primarily Ukrainian, weren't they, at the time?
Well, that I cannot tell you. I don't know.
In Bregenz, then, your responsibility was to try to evacuate approximately 1,000 patients from that hospital of military wounded.
Right.
Where'd you send them? Just out
Where?
of curiosity.
Oh, that I don't know. The train was coming, and I was putting in the train those who could leave the hospital.
Oh, I see.
After that, I don't know where they were going. This was not my problem.
Yes.
My problem was to find the SS at first, and after to evacuate the SS on one side and the wounded of the countries which were not Germany after.
When you identified SS,
By the tatouage.
yes, but when you identified them, were these turned over to the military police, or what happened to them?
I don't know. This was not my problem.
Yes. And shortly thereafter, you ended your military service in the city of Innsbruck,
Yes.
and then returned shortly to Paris, and commenced once again your internship, which initially was with Professor Petit-Dutailly in neurosurgery, and I assume it's in neurosurgery.
Now, at that time, the service was a service of general surgery.
Yes.
But Petit-Dutailly was operating a case of neurosurgery every week,
Yes.
one or two cases.
At La Pitié Hospital.
No, in
Still at Salpêtrière.
in Bichat.
Oh, Bichat, sorry.
Bichat.
And then following that, you had completed a year and more, actually, in pediatric surgery at Cochin Hospital and Les Enfants Malades.
Mm-hmm.
And after that, your last year of internship was with Professor.
When I was in
Yes.
Cochin, I was attracted by pulmonary surgery, which I thought could replace neurosurgery if I had not the possibility to do it.
Was that mainly secondary, the disease secondary to tuberculosis or
No
was
tumors,
of tumors?
cyst.
I see.
And this was also the beginning of heart surgery.
Yes.
So there was a specialty which I agreed to do if I could not become a neurosurgeon.
I see.
But finally, the death of Professor Clovis Vincent has changed my way.
I wonder if you would clarify that a bit. In what way Professor Vincent's death was instrumental in your entering neurosurgery?
For me,
Yes.
because one of my chiefs was Pertuiset, who succeeded to Clovis Vincent after his death. And Pertuiset asked me if I agreed to become his first assistant
Yes.
in neurosurgery. And I say yes.
At that time, were you commencing your final year of internship with Professor Alazouanine?
Yes.
And that was at Salpêtrière or at
Yes.
Pichon?
No, no, à Salpêtrière.
Salpêtrière. And what type of work did you do that year? Was it entirely clinical, or was it general neurology?
It was general neurology. It was clinical. I have learned to examine a patient and to know what was his disease. But at this time, this was the beginning of the EEG period. And it was very difficult from the EEG to go more closely into the diagnosis.
Yes.
So I was very much pleased when I came back from Montreal and I was able to use angiography. Because between Alazouanine and my first year in neurosurgery, I went to Montreal where I worked in the laboratory of Professor Jasper in the MNI under the chairmanship of Wilder Penfield.
Was that at the urging of, or with the support of Professor Alazouanine or Professor
Pertuiset.
And what particular type of work, form of research were you to engage in Montreal at the Neurological Institute?
Well, the main problem at this time was to know from where were coming spike and wave bilateral EEG. And as you know probably, Professor Penfield thought that the origin was into the nuclei of the thalamus. So all the MNI was working on the project. This was really a great family with many people coming from abroad. And this was one of my problems, is to know if surgery in this spike and wave epilepsy could have a future or not. And in fact, what I have learned is that if there was a future, I had to wait at least 10 years to know if the success of surgery was prolonged in time. This is what I have learned. Wait.
But what were your impressions of Dr. Jasper and Dr. Penfield?
Well, they were great doctors, and especially Penfield, of which the quality and the intelligence has been over all the masters which I have in my life. And he was really a great man. And it was a pity that he left the MNI.
Did you come to know Dr. William Cohn
Yes,
at all?
but I did not work with him. we had relations during rounds. The same with Elvidge,
Yes.
Baldwin.
And Dr. Jasper, was in neurophysiology.
Yes.
And what work did you succeed in accomplishing there in Montreal?
Well, two works. One with George Austin on cats. He was trying to find into the brain of the cats suppressive center. If you stimulate, you suppress the spike and wave. Well, during 1 year, we did it, and we did not discover, for sure, such areas. Now, the second work was clinical. Professor Penfield was kind enough to allow me to go over the files of the patient he had operated. So this was a big work, you know, beginning in the morning at 8 and finishing at midnight, which my wife did not like very much because I could not have lunch with them. But I have learned a lot, and especially what I have already said is that you must wait in order to know if what you have done will be or not a success.
Did you often or seldom find any evidence of sclerosis in the brain specimens you studied?
I did not study brain specimens.
What were these?
They were...
this is part of the tumor collection?
No, this was from a pathologist.
Yes, yes.
Well, Penfield published a book in which he said that there are areas of sclerosis into the brain at the origin of epilepsy. But I must confess that he has been the only one to say that.
I see. So you did not, you were studying though the cerebral cortex and white matter removed at surgery?
No, no.
Oh, okay.
No, it was studied into the MNI by the pathologist.
Yes.
Pathologist, which was, I think, Van Buren.
Mm-hmm.
I'm not sure.
That's correct. I think you're right. Then after you returned from Paris, what did you do the next? Then you remained under Professor Petit de Taillis' service?
Yes.
And for how many years?
I think from 1950 to 1961.
What?
And then the one who has taken the place of Petit du Taillis when he retired was Marcel David, which stayed in La Pitié until 1969. And then I became the professor of neurosurgery in La Pitié. So the succession was Clovis Vincent, Petit du Taillis, Marcel David, Bernard Pertuiset.
I see. When did you retire officially?
I retired the 1st of October 1990.
I see. And who is your successor?
My successor is called Foano, Denis Foano.
And you trained him?
I trained him, yes, that's right. He was my assistant professor.
Yes. In your earlier years, you had divided up your training periods and also your bibliography and those papers that pertain to neuroanatomy, neurophysiology, neuropathology, neurology, and neurosurgery. In the 1960s, as we were talking earlier, you had described an increasing interest in aneurysms, intracranial aneurysm surgery. that I understand has led to a great deal of interest to you and for you in the past decade or more. Was there anything particularly about aneurysms that attracted your interest, that you regarded as a particular challenge in contrast, say, to brain tumors?
Well, you are a neurosurgeon, as I was. What is nice when you are a neurosurgeon is to cure a patient.
Yes.
We cannot cure malignant tumors, but we can cure an aneurysm, which is a malformation. And this is one of the reasons why I have devoted a long part of my life to vascular malformations of the brain. Now, everything began to be better with the refinements of the diagnosis coming from the CT and coming from the MRI. And the operations also were facilitated by the use of the operative microscope and the use of these spring clips,
Yes.
which, of which the best, in my opinion, are those which are made in Germany.
Yes. You use both the temporary clips and the permanent clips?
Well, I have used temporary clips only when necessary.
Yes. Yes. Mm-hmm.
There was a paper in one of the last issues of Surgical Neurology
Yes.
about the use of the temporary clips,
Yes.
and they had some problems.
Yes, one difficulty is that if their pressure is reapplied several times, you can no longer predict the force with which the teeth will fit, will close and hold. That's one
Well,
problem.
you must use a new clip every time.
Yes,
It is costly, but
Yes.
it is better for the patient.
yes. As far as the development or improvements in morbidity, mortality rate for aneurysm surgery, what do you think are, say, the first 2 or 3 most important developments that have changed the rather pessimistic picture that prevailed, at least in some neurosurgeons' experiences from the early 1960s?
Dear Dr. Selby, you want a lecture?
No, sir. I would just like you to quickly mention what you felt occurred in, say, the mid to late 1960s that did make such an impact upon the morbidity and mortality of aneurysm surgery.
Regarding the morbidity, it is certain that the fact to retract a slack brain is very important. If you try to retract a swelling brain, then you have a morbidity.
Yes. So would you say urea, and I know in Paris they used, you used urea mannitol in combination in the mid-1960s?
Not urea, only mannitol.
Only mannitol?
And pentothal.
And pentothal. And the relaxed brain, and did that include usually the drainage of spinal fluid?
Not for me.
All right.
I never used this technique.
All right. And was controlled ventilation an early technique that was employed, or was that delayed until the 1970s, where the patient was placed on a ventilator and automatically ventilated by anesthesia with monitoring of blood gases? Did that come into common usage for aneurysm surgery?
I did not follow what you are speaking about. Aneurysm or...
Respiratoire control. Controlled ventilation by machine, breathing for the patient.
Well, when it is necessary,
No,
of
no,
course.
but I mean, you did not use this routinely either.
No.
Okay.
No.
And the development of the microscope, your introduction of the microscope to neurosurgery at Le Pitié, approximately when was that?
I think that the first microscope, which I had two in La Pitié, and coming from the setting. The first one came in 1972, and the second one came 2 years after. And this has been a great change, of course.
Yes.
This is not microsurgery. This is only surgery under the microscope.
Yes.
Microsurgery is only for the biologist. But under the microscope, you have a clear vision because the light goes in the same direction as your eyes.
Yes. Now, as far as the
No shadow.
yes, as far as the diagnostic radiographic procedures are concerned, you utilized extensively, I'm sure, angiography for many, many years for discovery of the not only location and size, obviously, but also the parent vessel to which the aneurysm belonged, really. We were discussing earlier about the association of atherosclerosis with aneurysms in your experience, which had also been mine. Do you feel that atherosclerosis is an important pathogenetic influence on the development of aneurysms in the adult human?
Good question. Very difficult to reply. The Japanese have studied that very much extensively, but the Japanese are not the French. This is another race. So I have no idea. But what I want to say is that it is possible now to evidence an aneurysm before rupture without angiography.
You mentioned CAT scans and MRIs. The CT scan with enhancement, were you generally using that more often than MRI in the recent years for the diagnosis of aneurysms, the unruptured aneurysm?
Well, we began to use CT scan when the machine were of very good quality, like the General Electric one. And also when we were able to inject very quickly a contrast media into the venous system. Now, if you do that, you visualize the blood which is inside the sac of the aneurysm. Now, if you perform an MRI, you can visualize the sac even if there is no blood inside. As you know, there are some aneurysms in which there is no blood when you examine the patient, and they rupture 1 month later because there was a small clot in the neck.
Yes.
I am sure that angiography will not be necessary for rupture and non-rupture aneurysm in the following years.
After the major institutions or average hospitals have MRI facilities, you mean?
Well, yes, it's incredible how it went very quickly. It came very quickly.
Yeah.
For the CT scan, we needed 10 years in order to get it.
Yes.
And now there is in Paris 25 MRI.
Really?
Yes.
We experienced the same problem with CT introduction in the United States, largely because of imposed governmental regulations. As far as positron emission tomography, do you feel that that may have a role in determining or aiding in determination of the functional status of the brain prior to surgery and following surgery in the early days or perhaps weeks?
Well, I don't know because I have not the experience of this machine. There is one which is not far from La Pitié, but it is very difficult to get access to this
Yes,
machine.
that's one of the problems because there's so few and they're so
Yeah.
expensive. As your recent experience has shown you feel that the morbidity and mortality rate of unruptured aneurysms today should be approximately what? Or what has been your experience with?
You mean after surgery?
Yes, sir.
After surgery, there must be no morbidity if you have a good technique. Now, regarding mortality, there is one if you operate patient which must not be operated. I give you an example. If a man is alcoholic, if he has diabetes mellitus, and if he has an aneurysm, don't operate him. There is a risk, not only regarding mortality, but also morbidity. So you must be conscious that there are some patients which do not deserve surgery.
Now, you also have come to advocate, as others have, the early intervention surgically of for the clipping of aneurysms that have bled, but during the first 48 hours prior to the appearance of spasm, with also a lowering the morbidity and mortality rate. What do you think required so many years for it to become evident that it was spasm and not a re-bleeding of an aneurysm that was responsible for the deterioration of patients after several days after the initial hemorrhage?
Well, we found the existence of spasm when the patient was aggravating his condition and when we performed a lumbar puncture. And the lumbar puncture showed that it was not a rebleeding. So we performed an angiogram and we showed spasm. So we could understand many of the complications of this rupture aneurysm. And you must know that what the Japanese publish is not correct. That means that if you remove the clots at the base of the brain, you don't have the certitude that spasm will not come. And Professor Sano, who is a good friend of me, said that many people lie about that.
Why, do you think?
Why?
Yes.
Oh, well, it's very easy to say. I agree to say it. Because the young who are in charge of the patient during the night want to operate aneurysm. And this is why they operate aneurysm early. And I don't think that this is a good way of treatment for the aneurysm. They must pass the 5th day, which is the day of the apparition of the spasm. If you operate the patient on the 1st day, and if the spasm appears, your patient will die, and you will be responsible.
Do you believe that surgery in the absence of spasm, that surgery to clip an aneurysm will initiate or aggravate the development of spasm?
No, I don't think so.
Okay. So that during the first day or two following subarachnoid bleeding, in the absence of spasm, and with the patient who is conscious, perhaps with minimal neurological findings, would you advocate surgery? Would you perform an operation to clip the aneurysm?
Before the 5th day?
Yes, sir.
No.
Not during
I
the
would not
first
do
or
it.
second? Why not?
Because if you operate the patient on the 2nd or 3rd day,
No, the first or second day.
yeah, first, second, he can develop a spasm on the 5th day.
Yes, sir.
And he can die of this spasm and not of your surgery.
Yes, sir. But if you do not believe that the surgery has played a part in the development
No,
of
I don't
the
think so.
spasm, then
The percentage of spasm is the same in all countries.
yes,
Percentage.
yes,
And this is 11%.
yes.
And among this 11%, there is 5 or 6% who will die anyway.
Yes. 10 or 11 years ago or so, there were the beginnings of more and more papers, though, in our journals advocating early surgery for bleeding from aneurysms if the patient's neurological status was excellent or was only slightly impaired, and if there was no demonstrable spasm on the angiography. But you do not hold to that idea.
The problem is when the spasm is coming, which day?
Yes.
You must have a big series. My series is 825 cases. The spasm appear always on the 5th day.
Yes.
And it develops or it stays. If it stays and if the patient is in good condition, then you can operate a patient who has a spasm, but not before the 5th day.
Do you have any personal...
Well, this is my opinion. Huh?
Yeah, no, I understand. Do you have any opinions of your own, though, about the mechanism underlying the development of spasm? Mm-hmm.
What I know is that there are families which create spasm. And this is why the percentage is always the same. I think that spasm is inscribed into the genes, into the chromosome. It was about 15 years ago. There was a girl coming from the United States. She was 16 years old, and she was traveling for pleasure in France. She had an hemorrhage coming from an aneurysm of the internal carotid artery. The diagnosis was made by angiogram at this time. She was in very good condition. And finally, I have operated her on the 4th day, or 3rd day, maybe. On the 6th day, she began drowsy. On the 7th day, she had an hemiplegia. Then we performed an angiogram, and there was a spasm like that of the carotid artery and bifurcation, and she died. Now the father came to me. This was in the American hospital. And so I tell him what happened. And he said, I am not astonished, because her mother died the same way as well as the aunt.
Are you aware of any published work on possible genetic factors in spasm?
Well, I am sure that in the Journal of Neurosurgery, there was a paper coming from Sweden about that. And it is a long time ago, more than 10 years. And when I wrote my book on aneurysm, I tried to find back this paper, and I did not find it.
To change the subject quite a bit, how many departments of neurosurgery training programs, departments having training programs in neurosurgery exist in France today?
26.
And what is the duration for the entire training period for a neurosurgeon?
7 years.
And that agrees with that in Germany?
Yes.
Though the content may differ.
Yes, that's right.
I believe you told me earlier that 4 years of internship are still required, and an additional 3 years of direct training in neurosurgery. After which, what does the doctor receive? Does he have to take an examination at the end of that time?
Not in France.
Mm-hmm.
He has not to make an examination. And this is the l'ordre des médecins.
Yes.
I don't know how to translate that in English. L'ordre des médecins give a paper telling that you are a neurosurgeon.
Yes.
And from this time on, you can have a private practice as well as a public practice.
That would be equivalent, I think, to our state licensing board directors, or the secretary of our state licensing boards. We don't have an exact equivalent to that. But that's after, of course, we've had examinations after medical school or after internship.
The only country in Europe which is different is United Kingdom, because there they ask 4 years of general surgery.
Yes.
So Europe do not agree with the British about that. But you know, British are stubborn people.
Well, the specialty of neurosurgery, nevertheless, has grown in every country, as far as I'm aware, from the field of general surgery as a rule. I mean, there are exceptions. Ottfried Förster in Germany, I mean, individual exceptions. Do you feel that, and until within the past few years anyway, there were still some doctors in the United States who felt that there should be still a strong general surgical background possessed by a doctor before he entered training as a neurosurgeon. Do you have any feelings like that?
Well, I think that your problem in the States are the same as in Japan. Too many neurosurgeons, which have not sufficient experience to be a good neurosurgeon.
Yes.
One of my friends, which I will not say his name, had a terrible suit after surgery of an acoustic neurinoma. But he was operating one neurinoma every year only. This is not sufficient.
How many neurosurgeons are there in France now, both academic and non-academic neurosurgeons?
It is not easy to give the exact number. I should say 450.
And roughly what ratio is that number to the population in France?
Population is 56 millions. So it is correct. It is correct until 500. After 500, I don't agree.
And how then do you limit the number of neurosurgeons in France?
That's a question that you must ask to the British.
Well, I understand the British method. But,
it is very efficient, the British method.
Yes.
You cannot operate outside a general hospital with university. But I must say that for the last 5 years, there are foreigners coming from the Middle East who have the right to operate in private clinics without having a foot into the university hospital.
I see.
So the situation actually is not as good as it was 10 years ago. And we must be very careful not to go in the path of the Americans or in the path of the Japanese.
Yes. And also perhaps in the path of the British, who have rationed the numbers of positions for neurosurgeons very stringently, though it's more liberal today than it was 30 years ago, 25 years ago. Do you have any thoughts about the future as far as the training, content of training for neurosurgeons? Should there be a change in emphasis in the types of, for example, trauma to the nervous system is such a great problem in France and the United States and Germany, everywhere, India. Do you feel that greater emphasis should be placed upon the management of head and spinal trauma during the training years of neurosurgeons than perhaps on treatment of aneurysms and tumors, which might be referred by them to more larger departments?
We must fight for prevention of the accident. And regarding the cars, it's very easy. No alcohol at all. Regarding the car also, a car in good condition. Now, no smoke into the car. If you don't do that, you will have the same kind of trauma that we have now after 10 years or 20 years, exactly the same, in which, in this case, mortality and morbidity is very expensive for the nation, for the society. So regarding the treatment of this trauma, it is depending upon the age of the patient. It is depending upon the severity of the brain laceration and so on. I don't think that we are actually improving the treatment of these poor people.
At the end of your bibliography, which numbers now approximately 350 papers and other publications related to neurosurgery and, well, medicine, there is a quotation that I would appreciate very much your reading, or translating, rather.
Well, I shall try to translate. Man is his own master, and there is no human being or power which can judge about his destiny. Buddha, Yahweh, Jesus, and Allah have encouraged and stimulated every human being to develop himself and realize his proper emancipation, because man has the power to liberate by himself of all obstacles by the grace of his personal effort and intelligence.
Thank you very much, Professor Pertuiset.
Thank you, Dr. Selby.
Thank you.